Hello everyone. In this video, I will be discussing about a very important electrolyte disturbance, hypomagnesemia. Even though magnesium is the second most abundant intracellular and the fourth most abundant extracellular cation in the body, even you would not have so far read about hypomagnesemia in all these years. Compared to hyponatremia, hypokalemia, hyperkalemia, hypocalcemia, all these things are usually read. Maybe you don't know, that may be the reason this is asked as a short note question in 2024 university exam. These years, the trend has completely changed. The weightage of questions from endocrinology, rheumatology, hematology, and infectious diseases has gone rapidly high. So in this video, let us discuss about hypomagnesemia in detail. Magnesium is required for all enzymatic reactions. Hope you know ATP, adenosine triphosphate, kinases, because it is mainly helpful for neuromuscular excitability. See, central nervous system is the first system to get affected or to show symptoms in case of hypomagnesemia, along with regulation of ion channels, mitochondrial function, cellular proliferation, and apoptosis, as well as it has a role in immunity as well. So what is hypomagnesemia? It is defined when the serum magnesium is less than 1.6 mg per deciliter, and the symptoms start when the level falls less than 1.2 mg per deciliter. So remember 1.6 definition, symptoms 1.2. Okay. So you can see here, see this is actually a journal. So the clinical research on hypomagnesemia is very less compared to the rest of the electrolyte disturbances. So as I told you, the first important system is CNS, which shows the clinical manifestations of hypomagnesemia. That is neuromuscular hyperexcitability, that is tremors, fasciculation, tetany, convulsions, neuropsychiatric disturbances, apathy, delirium, and even coma. And the life-threatening complications are not because of hypomagnesemia, it is because of associated hypocalcemia and hypokalemia that causes ventricular arrhythmia, torsades de pointes, digoxin toxicity, sudden cardiac death. Okay, I hope this is clear. Fine. So let us see about the magnesium functions, enzymatic activities of ATPases and kinases, membrane function, as I told you, to help in transmembrane transport and cell adhesion. Calcium antagonist function helps in neuromuscular function, and of course enhanced apoptosis. Okay, all those protein polyribosomes, multiple enzyme complexes, and everything. So why these enzymatic activities are important? Because it causes altered glucose metabolism and electrolyte imbalance. That is why I told you, whenever there is hypomagnesemia, we have to always look about associated hypokalemia and hypocalcemia, because that is responsible for the life-threatening effect like arrhythmias. Okay, that is mainly because of the defect in the membrane function, and it is the calcium antagonist function that is responsible for the neuromuscular hyperexcitability, tremors, fasciculation, psychosis, vertigo, nystagmus, acetoid and coliform movements, etc. So coming into the metabolism of magnesium, remember 20 to 80% of the dietary magnesium is observed in the intestine via two pathways, active as well as passive pathways. Remember two transporters that is responsible for magnesium transport. One is TRPM, transient receptor potential melastatin. Okay, 6 and 7. Just remember TRPM 6 and 7. Okay, and not just in GI. Okay, kidney is the major organ that handles magnesium properly. Okay, so magnesium exists as a protein bound form, complex with organic anions like sulfate, phosphate, bicarbonates, and citrates also. So now let us see about how the kidney handles the magnesium. This simple picture is enough to understand how the kidney handles the magnesium. See, nearly 70 to 80% of the plasma magnesium is ultra-filterable, and in the proximal tubule, nearly 15 to 25% of the passive reabsorption of the magnesium takes place along with sodium and water, and the major absorption of magnesium via the paracellular transport takes place in the thick ascending loop of Henle, which is nearly 65 to 75%, and via the TRPM6 transporter at the DCT, nearly 5 to 10% transport occurs. So that is why, remember, 65 to 75% is observed in where? Thick ascending limb of the loop of the Henle. Okay, yes, and fine. And remember, so just remember that 65 to 75% in the thick ascending limb. There is no need to know the details of it. And when it comes to hormonal regulation, it is aldosterone which has been reported to induce renal magnesium wasting. Okay, that is why hypomagnesemia is triggered by aldosterone antagonist. Okay, like spironolactone, epinephrine, all those drugs. Okay, so remember, aldosterone is one of the important hormone that regulates. So coming into the etiologies of acute hypomagnesemia, first is GI cause, low dietary magnesium intake or losses like diarrhea, steatorrhea, celiac disease, regional enteritis, and short gut syndrome. And when it comes to cellular shift or tissue sequestration, acute pancreatitis, remember, it causes hypocalcemia and hypomagnesemia because of the saponification of the necrotic fat. And hypomagnesemia is also associated with a massive blood transfusion. And recently, a new antiviral drug called foscarnet has known to increase the incidence of hypomagnesemia. So now let us see the table. Actually, what are the etiologies? Gastrointestinal obstruction, as I told you, both active and passive means TRPM6. Okay, hypomagnesemia will be there, but there will be always associated secondary hypocalcemia. Then, as I told you, what proximal tubular acidosis or Fanconi syndrome of, causes again hypomagnesemia. Thick ascending loop of Henle, as I told you, 65 to 75% is causing. Okay, yeah, here one mutation is there, that is claudine 16, claudine 19 mutation. And in DCT, as I told you, nearly 15% is observed. So whenever there is the so-called as the gentleman syndrome, okay, there will be associated hypomagnesemia also. And in thick ascending loop of Henle, we have again Bartter syndrome. Okay, Bartter syndrome type 1, type 2, type 3, all those are associated with the hypomagnesemia. Hope you would have read this in medicine properly. So when it comes to renal wasting, as I told you, hyperfiltration. So the first problem where we are going to target at the glomerulus, because at the glomerulus only the first this magnesium is reaching. Okay, whenever there is acute tubular necrosis, renal tubular acidosis, diabetes mellitus, there will be hyperfiltration. So that again causes what hyperfiltration means, what more magnesium is lost in the urine. Yes, or because of reduced proximal tubular reabsorption, again there is severe injury to the nephron segment. So what will happen again? It causes hypermagnesiuria, that is magnesium is lost in the urine. So low dietary magnesium intake, acute pancreatitis, hyperfiltration, loop diuretics. Yes, because 65 to 75% obstruction take place in the thick ascending limb of the loop of Henle. So nearly loop diuretics can cause what? Hypokalemia. Loop diuretics causes every electrolyte still loss. Okay, it causes hypokalemia, it causes hypomagnesemia, everything. Okay, yes, so that also causes. And the DCT, remember, there are two drugs, that is calcineurin inhibitors. In the recent research, we have found that cyclosporin, tacrolimus, rapamycin. Rapamycin is the target, what? Mammalian target of rapamycin, mTOR agonist. Okay, so that is rapamycin, and that is responsible for causing, these drugs are also causing hypomagnesemia. Okay, so loop diuretics, aminoglycosides, remember, and in DCT, cyclosporin and tacrolimus, remember. Okay, so when it comes to a diagnosis of hypomagnesemia, always rule out associated secondary hypocalcemia, hypokalemia, because that is responsible for the life-threatening manifestations of hypomagnesemia. Yes. So coming into the management, how we can manage it? First, we can do routine correction of the hyperfiltrative state. We can correct the metabolic acidosis. For example, whenever there is hypophosphatemia, hypoproteinemia, protein wasting disorders like in diabetes mellitus, what will happen? Of course, hypomagnesemia occurs. So remember, always kidney is the most common cause. First kidney, then rule out the GI loss. Then so reduction of glomerular hyperfiltration, that is always achieved by a newer group of drugs, that is called as ACE inhibitors, angiotensin converting enzyme inhibitors. And dietary intake of foods containing high levels of magnesium like almonds and spinach, cashew nuts and peanuts, cereals, everything has to be increased. And of course, we have a lot of oral formulations of magnesium in the form of magnesium oxide. So with this, I came to the end of hypomagnesemia. Remember, unlike other electrolyte disorders, we won't read this, but hypomagnesemia, yes, it is important. Okay, we have to, coming into the treatment part, we have to reduce the hyperfiltrative state, we have to reduce the acidosis, we have to rule out the kidney problem and GI losses. Then magnesium supplements, food sources, I told you, almonds, cashew nut, peanuts. Okay, then ACE inhibitors are used. Then remember, when it comes to absorption, it is thick ascending limb. Yeah, that is why there are hypokalemia, loop diuretics, and aminoglycosides act, and DCT, cyclosporin, tacrolimus, and rapamycin. And as I told you, what are the other causes? Yes, it is GI loss and acute pancreatitis. Then aldosterone is a hormone which helps in regulation of this magnesium. Just remember this table. Okay, 65 to 75% occurs at the thick ascending limb of loop of Henle via the so-called as the paracellular transport. Yes, so remember this. And once that is done, as I told you, yeah, what are the manifestations? Neuromuscular hyperexcitability. Okay, and the life-threatening manifestation is not purely because of hypomagnesemia, it is because of associated hypokalemia and hypocalcemia. Defined serum magnesium less than 1.6, symptoms occurs less than 1.2 mg per deciliter. Thank you.